psychoses that have these hallucinations that are unreal. The voice frequently in an alcoholic that they're hearing is threatening voice. It makes them scared. They might hear a train whistle or background music. One patient was hearing a voice coming out of his water faucet that I had. So that's the auditory hallucinations. Visual hallucinations are about 80%. They're the most common type of hallucination. Alcoholic can have hallucinations in color. They actually see, it's not black and white. Things that are of inappropriate sizes. If they see a cockroach, it's a big cockroach. If they see a snake, it's big. It's usually threatening. It's usually unpleasant. The things that they see, they don't see flowers or something like that. They see something unpleasant, deadly, life-threatening, like out of a horror movie. The hallucinations for the alcoholic are worse when they're supine, when they're lying down. And they're better when they get up out of bed and start walking around. That's ironic because what we do when patients are in bad alcohol withdrawal is we have to strap them in a bed supine, and that makes their hallucinations worse. Olfactory hallucinations are smelling things that aren't there. Usually, again, it's bad smells. Those are more rare. And tactile hallucinations. They can feel glass underneath their skin. They can feel bugs crawling on them. Frequently, if they're having these tactile hallucinations or smelling hallucinations, DTs, delirium tremens, the stage that I'll talk about in a minute, is going to come on pretty quickly. Stage 3 is the stage of seizures. The seizures in alcohol withdrawal are always grand mal seizures. They're not shaking, they're not tremor. These are grand mal seizures, full-blown loss of consciousness, falling to the ground. They usually occur before DTs rather than after. They occur in about 10% of those in withdrawal, so they're pretty common if they're not treated. Some doctors think that if you give them seizure medicine, that'll prevent the seizures in DTs, in alcohol withdrawal. They don't really work. There's usually only one seizure. They can occur in a group of 2 or 3, but there's usually only one. They usually last just a minute or so. A patient can go from this stage 2 hallucinations to right into DTs without having a seizure. About 1/3 of the patients that are having seizures go on to DTs if they're not treated. So stage 4 is the stage of delirium tremens, and this is what we try to prevent with all the medication that we get. The person that we talked about, the case that I presented, we want to prevent that. That's not a good outcome. DTs are a medical emergency. It's a dangerous condition. It requires transfer to the intensive care unit for monitoring IV medication. It requires restraints, medications. Sometimes you have to put them to sleep and put them on a ventilator to breathe for them. You got to put them into a medically induced coma in order to treat the DTs. DTs doesn't occur right away. It occurs about 72 to 96 hours after the last drink, so 3 or 4 days later. It's been reported in about 5 to 12% of patients. The signs and symptoms of DTs are confusion, delusion. They don't know who they are. They don't know where they are. Delirium, agitation, horrible agitation, tremor, hallucinations. They get autonomic hyperactivity. Our nervous system has the central nervous system, which controls our thinking and movement, but the autonomic nervous system controls our blood pressure, pulse, sweating, temperature. That goes haywire too. It goes into overdrive. And they get fever, tachycardias, fast heartbeat, high blood pressure, drenching sweats occurs in DTs due to that autonomic hyperactivity. The prognosis, DTs can be fatal. The historical mortality, it used to be about 40% of people in DTs would die. It's not nearly that much anymore. It's about 5% because we've gotten better at treating it. The reason they die is because the heart, being in overdrive, just gives out. They'll go into a heart arrhythmia, a ventricular fibrillation, a cardiac arrest, and we can't get them back. The heart will just stop. Also, they may aspirate, get pneumonia, and die from that. they may get electrolyte disorders or may get dehydrated and may die from that. So what are the risk factors? Who's going to get DTs? Anybody with a history of sustained drinking, anybody with a history of previous DTs. I've seen this over and over again. If somebody's had DTs and they come back in, they're likely to go through DTs again. Usually it's in somebody older than the age of 30. If they have another illness going on like pneumonia, it makes them at risk for DTs. Again, if they have a high blood alcohol level and they're already in withdrawal, they're at risk for DTs. And anybody with withdrawal present 2 or more days since the last drink is at risk for DTs. So stage 5 is the protracted abstinence syndrome. And this is a stage that can occur with people that are here even now, because this can go on for months after, 3 weeks up to 3 months after withdrawal. It's also called post-acute withdrawal. This is important because the symptoms in this stage that we'll go through can lead people back to drinking again. It can lead them to relapse. And that's probably why 80% of the relapses occur in the first 6 months. 80% of the relapses occur in the first 6 months. So the symptoms of this protracted abstinence syndrome, and you can see if any of you have this now: anxiety, irritability, hostility, depression, insomnia. 70% of people will have insomnia during this stage, this first few months after stopping drinking. Fatigue, headaches, maybe some nightmares, tremors, dizziness, stomach complaints, mood instability. There's a continued need for alcohol to feel normal, or perceived need for that. There's continued craving, conditioned stimuli. That means like an alcoholic going back to an old place where he used to drink, maybe an afternoon bar, maybe going into a bar at night. That can cause relapse and cause them to crave, because it can cause withdrawal, can make them start shaking, or it can cause them, even without drinking, to actually feel like they're under the influence of alcohol. So going into a bar in the first 3 months is very dangerous for the alcoholic. The only treatment for the protracted abstinence syndrome is simply staying sober. It does go away with time. Some people have talked about using the medication naltrexone, which we'll talk about, or gabapentin can be used during this protracted abstinence syndrome. So how do we treat alcohol withdrawal? There's a couple different methods. There's a method called front loading. And this is giving a large dose of medication, a large dose of benzodiazepines usually, to everybody right when they check in. This is what might be used by a public detox center. You go in and you're going to get a big dose of Librium. This might be used by a medical hospital that they don't really know how to treat alcohol withdrawal real clearly, so they just treat everybody the same. They put them on a protocol, everybody gets the same, and then the med will self-taper. The problem with this is it's just not individualized. Some people are going to get way too much medication because they just don't need it. Other people aren't going to get enough medication because everybody is given the same amount. So it may be good when patients are difficult to assess, or when there's minimal staffing, or the staffing doesn't really know about how to treat alcohol withdrawal. But the best way to treat alcohol withdrawal, the best method, is what we call symptom-triggered therapy. And this allows rapid delivery of the right medication to the person based on how many symptoms they're having. So if a person needs a lot, they'll get a lot. If they don't need much, they won't get any. So that's what we do down on the detox unit on 3A, and that's the method of choice. This requires the use of withdrawal scale scores, though. Ambulatory detox we'll take and discuss in a minute. You have to be able to assess the patient, and what we do is we put them on a scale. There's lots of different scales that we'll mention in a minute that give the nurses an idea of how bad the alcohol withdrawal is at any particular moment, so that then they can be given the right amount of medication. When you're doing this, you need a good nursing staff. You need comprehensive and regular education of the nursing staff, so that they understand alcohol withdrawal and what to look for. It's important to treat high-risk patients aggressively right away. You have to hit them hard. You have to identify it quickly. The nurses have to be really good at it in order to stop the breakthrough withdrawal. We had a patient, I didn't have a patient, but another doctor presented a case of a patient that shows how if you don't treat a withdrawal quickly, how bad it can turn out. This was a 39-year-old guy admitted to a ICU because he was throwing up blood. His blood alcohol level when he was admitted to the ICU was 0.27. So he was drinking a case of beer a day. He had a history of alcohol withdrawal seizures, so they should have known that he was at high risk for detox. And he had been in detox several times, so a very high-risk patient. So he came in at 3 o'clock in the morning, and they started an Ativan drip. Ativan's not the best medication. Giving it by drip is not the best way. So at 3 o'clock, he got 2 milligrams. At 4 o'clock, he got 2 milligrams. At 5 o'clock, he got 2 milligrams. Kept going on. At 7 o'clock, he was restless, so they upped it to 3 milligrams. By 11 o'clock, he was aggressive, agitated, combative, so they upped it to 10 milligrams, and then 20 milligrams, and then 40 milligrams. And by noon, so 9 hours after he was admitted, he was in the intensive care unit, and he was intubated on a ventilator. He stayed in the hospital 23 days to treat his detox. He almost died because not the right medication was used, and it wasn't used rapidly enough. He came back to the same unit a year later, having been drinking the same amount again. And this time the doctors treated him with Valium, and they gave him twice the amount in the first few hours. His length of stay that time was 3 days. So much, much better. So it really is important to give the medications strongly at the beginning and to really have the nurses know what they're doing. So where do you treat alcohol withdrawal? Some people don't have bad alcohol withdrawal. They drink a lot and they don't get very sick. They can be treated as an outpatient. That's called outpatient detox or ambulatory detox. Who can do that? These are the criteria. That CWA score or MSSA score is the score that we'll talk about in a minute that measures how bad the alcohol withdrawal is. It really needs to be around 8 to 15. Under 8, they don't need any treatment. Over 15, they need to be in the hospital. Person has to have never had DTs or seizures. They have to be able to take oral medications. They have to have no unstable medical condition. They have to be psychiatrically stable. We wouldn't treat a pregnant patient as an outpatient. They have to have a stable living environment. They have to have somebody living with them that can watch them and see how they're doing. Can bring them to the doctor in the emergency room if needed. They have to be able to follow up in the clinic, come back the next day for another appointment. They have to have no history of DTs or seizures. I guess that's mentioned twice. They have to be under the age of 60. So if they don't meet that criteria, if they have any of the things that would eliminate them, then they need to be in the hospital, and we do what's called medically managed inpatient detox. Now the withdrawal assessment scores. There's a bunch of them that are used around the country. That first one, CWA AR, is probably what's used the most. It's been around the longest. We don't use it here at Fairview for reasons I'll tell you in a minute. But the withdrawal assessment scales quantify the severity of withdrawal by using a standard instrument or scale. It helps assess the need for the medication. It also determines the appropriate site, whether inpatient or outpatient. It helps gauge the response to treatment. How are they doing? Are they getting better? Are they getting worse? Higher scores indicate more medication and more frequent checks. It's been well studied. It improves care. It shortens length of stay and it reduces costs of care when you use these withdrawal assessment scales. Like I said, the CWA is the most common one used. It has 10 items. The AWCA, Alcohol Withdrawal Clinical Assessment, has 6 items. That's one that I found was used in California. There's one called the Glasgow Modified Alcohol Withdrawal Scale that has 5 items. There are tremors, sweats, hallucinations, orientation, and agitation. That's supposed to be as good as the CEWA. There's one that emergency rooms use called the SHOT. That's got only 4 items: sweating, hallucinations, orientation, and tremor. What we use here at Fairview, and we've been using it for years, is something called the MSSA. If you were on 3A in detox, that's what they measured you on. It's called the Modified Selective Severity Assessment. It's used here for many years. This one I like because it includes the vital signs. It includes the temperature, it includes the pulse, and I think those are important. There's even a new one called the AST, which is just anxiety, sweats, and tremor. So a lot of them can be used. The problem with these assessment scales is that there are false positives. This is when there's high scores, but the person's not in withdrawal. And that can be due to maybe they're intoxicated and they look delirious, or maybe they've got psych problems and they're hallucinating, or maybe they've got medical problems and they've got high vital signs, or maybe they're drug seeking. So you ask them to stick their hand out and they're really not in withdrawal, but they just go like this. And they say, I'm really, really shaky, or they splash water on their face in order to get more medication. A false negative, we see that occasionally. Some people would have low scores, but they're really having bad alcohol withdrawal. They just don't get very sweaty. They just don't get very shaky. When that's the case, sometimes I just put them on regular scheduled Valium. They also might have false negatives if they're on medication that mask the withdrawal, like beta blockers that slow the heart rate down. It's very important that the entire medical condition of the patient be considered. Patients should not be given points that are present that are not due to alcohol withdrawal. So you shouldn't get points for not eating if you have an eating disorder or if you've got stomach flu. Or you shouldn't get points for tremor if you've got a neurological condition called an essential tremor. Or you shouldn't get points for fever if you've got an infection. So how do we treat alcohol withdrawal? I'll go through the medications. The benzodiazepines are the treatment of choice nationwide. That's what we use. They've been around since the 1960s, and they work. It's evidence-based medicine that they're very effective in treating this alcohol withdrawal. They go to the part of the brain where alcohol works, the GABA receptor. They reduce withdrawal symptoms, they reduce seizures, they reduce delirium, and they decrease the progression to DTs, which is what we want.